My name is Dr. Patrick Ford. I'm Director of Thoracic Oncology at Johns Hopkins Hospital. Today, along with my colleague, Dr. Joshua Royce from Georgetown University, we're going to discuss some case studies in mesothelioma. The first case study I'll discuss today is that of a patient who is 67-year-old, a male, good performance status at presentation. He had had a dry cough for several months and described right-sided chest heaviness. He eventually underwent a CT, which showed thickening of the right pleura. You'll see that in the image with the red arrow pointing to the pleural thickening. And then underwent a biopsy via video-assisted procedure. And pathology from that biopsy was reviewed showing an epithelioid mesothelioma. Further staging, unfortunately, showed FTG avid, mediastinal, and hilar lymph nodes on PET-CT scan. He then underwent a bronchoscopy and then a bronchial ultrasound-guided biopsy, which confirmed that he had mediastinal involvement of his lymph nodes. At this point, I'm going to ask Dr. Royce to comment on first-line therapy options for patients with unresectable mesothelioma and perhaps why this patient might be deemed unresectable with mediastinal lymph node involvement. Dr. Royce?
Thank you, Dr. Ford. Yeah, so as you detailed the case here, based off of the positivity in the mediastinum there, the lymph node involvement, that to me, which was the trigger for this patient not being resectable with epithelioid mesothelioma. So when discussing frontline therapies, now we are very excited to have a frontline immunotherapy combination as an option in the standard of care setting for patients with metastatic mesothelioma. With this patient with epithelioid histology, we do know, however, that chemotherapy does provide some benefit. We already discussed the Checkmate 743 study, but we do know that patients with epithelioid mesothelioma tend to respond relatively well to chemotherapy. So I think if I were exploring this patient, I first and foremost would try to find a clinical trial that involved chemotherapy with immunotherapy, the combination. Outside of that, I do think it's reasonable to pursue treatment with upfront nivolumab plus ipilimumab, knowing that immunotherapy arm, the response and survival with the combination immunotherapy arm of Checkmate 743 was similar with chemotherapy versus combination immunotherapy. And we know that immunotherapy tends to work better in the frontline setting. So I would probably pursue frontline combination immunotherapy in the standard of care setting for this patient.
Sure. Yeah, I think that's a very good point and a very recent development in the treatment of mesothelioma. In this case, this patient's presentation predated the Checkmate 743 date, and he was treated with pemetrexed and cisplatin upfront, which has been our first-line treatment for mesothelioma now for almost 16 years prior to the recent FDA approval. He had an initial tumor response, followed by tumor progression at approximately 8 months. Then we started to look at second-line options for him. And as you mentioned, Dr. Royce, clinical trials are always something we think of for mesothelioma, given the rarity of the tumor type and the paucity of treatment options up until recently. He received second-line ipilimumab, nivolumab in this case, with stable disease, however, eventually became more symptomatic and required placement of a Pleurex catheter. He did enroll in a clinical trial as third-line treatment, and this particular trial involved CAR T-cell therapy. Perhaps you can comment briefly on clinical trials for mesothelioma more generally in the relapsed setting, and also perhaps CAR T-cell therapy for mesothelioma.
Yes, certainly. So I agree. I think that in particular when patients progress on frontline therapy, and certainly that's when, as opposed to if, unfortunately, we have yet to really find a great durable option for our patients. I think clinical trials are definitely the way to go. And I think there are several interesting concepts that are being explored in mesothelioma, one of them being CAR T. There are several markers of mesothelioma, namely mesothelin, mesothelin-directed target or CAR T therapies are being explored in multiple clinical trials. So far in its infancy, in terms of response, but definitely something that mechanistically makes a lot of sense. I think the other interesting type of trial being performed are local delivery of therapy. So knowing that this is mesothelioma is by and large contained to the pleural space or the peritoneal space, it really makes it a potential ideal candidate for a locally directed therapy option. So I think these are the types of clinical trials that I'm always very interested in pursuing for my patients.
Sure. And so in this patient's case, he did have some symptomatic benefit from the CAR T-cell therapy, which was delivered intrapleurally for him. Unfortunately, after about 6 to 7 months later, he had clinical deterioration and passed away just over 2 years from his initial diagnosis. So today we've discussed the case of a patient with unresectable epithelioid mesothelioma. The patient was treated with the standard therapy at that time, which was pemetrexed cisplatin. We now have another option for these patients with the approval of ipilimumab nivolumab. And while there is significant benefit for sarcomatoid patients or non-epithelioid patients from immunotherapy, it can also be considered for patients such as this. We've also discussed that in the second or third line setting, clinical trials are a very good option for mesothelioma and should be considered probably at all stages of disease as we strive to gain new knowledge and new treatment options for mesothelioma patients. Thank you for listening today.